everyone, welcome to See and Perceive section. In this, I will be talking about postnatal assessment. The topic is arranged under following headings: Introduction, Definition, Purposes, Articles. Introduction. Primary responsibilities of nurse in postnatal settings are to assess postnatal patients, provide care and teaching. Postnatal nurses are essentially searching for findings that might lead to negative outcomes for patients if left untreated or unattended. Thus, it is imperative for nurses to distinguish between normal and abnormal findings to promote postnatal health and well-being. Definition. Postnatal period, also known as puerperium and fourth trimester, is the period that extends between 6 and 12 weeks after delivery. It is period after childbirth until the body has returned back to near pre-pregnant state, reproductive organs revert back to their normal position. As per ACOG, comprehensive initial assessment should be done within first 3 weeks of delivery, and ongoing assessment and care should follow till 12 weeks of delivery. Purposes: to assess physiological, social and psychological well-being, to check for potential medical problems after delivery, and to follow problem identified during antenatal and intranatal period, to find out the involution of various organs in mother. For teaching postnatal mother regarding care of herself and baby. Points to remember: take the patient to the examination room quietly, wash hands meticulously, maintain the privacy of patient using screen and sheet to cover her, safety of patient should be kept in mind, explain procedure to the mother, ask the mother to empty the bladder within 30 minutes before abdominal palpation. Loosen the clothes enough to allow access to the abdomen. Stand on the right side of the mother. Collect history of the mother. Articles. The articles used in the process are given in Figure 1. Tray containing articles for postnatal examination. Tray containing the following articles: BP apparatus, watch and torch, kidney tray and paper bag, sterile pad in a wrapper, cotton swabs. Hand washing articles, draw sheet, a pair of gloves, mask, gown, measuring tape, temperature pulse respiration, TPR tray, articles to record, pen, red, blue and black, treatment chart, cotton swabs, tray for perineal examination if required, weighing machine, screen. Steps of procedure. Pre-procedural steps. Explain procedure to mother, it promotes compliance. Assemble the articles at the right side of the patient to prevent inconvenience during procedure. Wash your hands well before doing assessment to prevent infection. Ask mother to empty the bladder for correct estimation of fundal height. Provide comfortable position to the mother, provides comfort to the mother. Provide privacy to her with the help of screen and do not expose her unnecessarily to reduce anxiety. Early assessment. Intra-procedural steps. History collection. Biodata, chief complaints, present history, past history, family history, menstrual history, contraceptive history, history of previous pregnancies, present obstetric history. Laboratory investigations: HP, blood group, blood or urine sugar, urine albumin, pus cells, venereal disease research laboratory test, HIV, HPS-AG, ultrasonography, etc. provides a baseline data about the patient condition. Physical examination. General physical examination, height, weight, vital signs and build. Vital signs. Temperature below 100.4 degree Fahrenheit during first 24 hours after delivery considered normal. Encourage fluids. If temperature is above 100.4 degree Fahrenheit, check the following for possible infections: lacerations, sutures, episiotomy and abdomen, breasts, lochia. Foul odor of lochia may indicate infection. Fundus. Tenderness indicates infection. Signs of urinary tract infection. Pulse elevation may be first sign of hemorrhage. Decreased pulse rate as low as 50 is considered normal during first postpartum week. Decreased BP and or narrowed pulse pressure are signs of shock. Orthostatic hypotension is common during the early postpartum period. The patient should rise slowly from lying or sitting to prevent blackouts or falls. Assess BP every hour. If patient has been pre-eclamptic, help in detecting any deviation from the normal physiological changes. Head to foot examination. Observe for following to detect any complication in the immediate postnatal period: head, infection, cleanliness, pediculosis, etc. Eyes, sclera and conjunctiva for pallor and jaundice, signs of infection. Ears, hearing abnormality, discharge, wax accumulation. Nose, discharge, deviated nasal septum DNS, epistaxis. Mouth, cracked lips, chelosis, dental caries and hygiene, gum swelling or bleeding and coated tongue. Neck, symmetry, shape and lymph adenopathy. Breast examination, symmetry, shape, primary and secondary areola, tubercles, inverted or flat nipples and colostrum. Hygiene of breast, especially nipples engorgement, adequacy or inadequacy of breast milk. Upper extremities, check for any bony deformity, capillary refill. Lower extremities, Homan's sign, edema, bony deformity and varicose veins. Bowel and bladder, constipation, incontinence, retention of urine and signs of urinary tract infection. Genital area, bleeding, discharge, infection, hemorrhoids and hygiene. Postnatal assessment. Many nurses find it useful to use the acronym BUBBLE-HE to remember the necessary components of the postnatal assessment and teaching topics. This is as follows: B. Breast, U. Uterus, B. Bowel, B. Bladder, L. Lochia, E. Episiotomy, H. Homan's sign, E. Emotions. Provides a guide for the thorough assessment in postnatal period. Breast inspection. Inspect the breast for its color, shape, contour, any abnormal discharge other than milk from the nipples. Palpation. Gently palpate each breast. If you feel any nodule in the breast, the duct may not have been emptied at last. Stroke downward toward the nipple, then gently remove the milk manually. Take this opportunity to explain the process of milk production, what to do about engorgement, how to perform breast self-examination and the questions that she may have about breastfeeding. Check for any tenderness, firmness and fullness. Check for engorgement of breast that is tender, painful and heavy. Breast, soft, engorged, fullness, swelling, redness and tenderness. Nipples, inverted, erected, cracked, bleeding, bruised and presence of colostrum and milk. Colostrum, yellowish fluid rich in antibodies and high in proteins. Engorgement, occurs by day 3 or 4 due to vasoconstriction as milk production begins. Lactation, ceases within a week if breastfeeding is never begun or is stopped. Helps in detection of breast complication that will create difficulty in breastfeeding. Abdomen, position the woman for examination. Place a pillow under her head and upper shoulders. Have her arms by her sides. Expose her abdomen from below the breasts to the symphysis pubis. Promotes relaxation of abdominal muscles. Inspection. Perform the following inspection: shape of abdomen, linea nigra, stria gravidarum and previous surgery scar. After the delivery of baby, the uterus myometrial muscle is well contracted and retracted with alternate hardening and softening and comes at the level of the umbilicus. After 10 to 14 days, the uterus will become a pelvic organ. The uterus measures about 20 by 12 by 7.5 centimeters at term and weighs about 100 grams. At the end of 6 weeks, it returns to pre-gravid state, that is 7.5 by 5 by 2.5 centimeters and weighs about 60 grams. Enables visualization of the whole abdomen. Clinical assessment of involution. The clinical assessment is done by noting the height of fundus of the uterus in relation to the symphysis pubis. Bladder must be emptied as the full bladder and bowel may raise the level of the fundus of the uterus. The uterus is to be centralized and with a measuring tape, the fundal height is measured above the symphysis pubis. Following delivery, the fundus lies about 13.5 centimeters above the symphysis pubis. During the first 24 hours, the levels remain constant. Thereafter, there is steady decrease in height by 1.25 centimeters in 24 hours, so that at the end of second week, the uterus becomes pelvic organ. Subinvolution of the uterus occurs when the uterus is not completely contracted and retracted, which will lead to postpartum hemorrhage, and this mostly due to full bladder, uterine atony, infection of bladder, retained products of placenta, position of uterus. Central, if displaced toward right, may be due to full bladder. Provides a guide for the assessment of normal position of uterus following delivery. Consistency of the uterus. The strong, frequent myometrial contractions that control blood flow to the uterus causes it to become hard. Its consistency can be assessed by palpating the uterus. It should feel firm and round. If the fundus is soft, it is called boggy uterus, which indicates that contractions are inadequate and blood continues to flow. Helps to rule out the atonicity of the uterus in the immediate postnatal period. Bladder. First of all, inspect and palpate the bladder simultaneously while checking the height of fundus. Teach her about the perineal care. Encourage for frequent emptying of bladder. She should wipe from front to back after voiding and defecating. Early ambulation should be encouraged. Assess for retention of urine. When bladder distension does occur, a pouch over the bladder area is observed or felt upon palpation, and mother usually feels need to urinate. It is imperative that the first 3 voidings should be measured and it should be at least 150 cc. Frequent small voiding with or without pain and burning may indicate infection or retention. Helps the uterus to contract and retract properly and prevent the atonicity of the uterus. Bowel. Ask the woman daily about bowel movements. She must not become constipated. If her bowels have not functioned by the second postpartum day, the doctor may start her on mild laxative. Auscultate for the bowel movement. Encourage mother to drink extra fluids. Have mother select fruits and vegetables from her menu. Increase fiber and fluid intake to prevent constipation. Encourage early ambulation for prevention of constipation. Genital area, lochia. It is the vaginal discharge for the first fortnight during puerperium. Odor and reaction. It has got a peculiar fishy smell. Its reaction is alkaline, tending to become more acidic toward the end. Color. Lochia rubra 1 to 4 days red. Lochia serosa 5 to 9 days yellowish and pink and pale brownish. Lochia alba 10 to 15 days pale white. Composition. Lochia rubra, blood, shreds of fetal membranes and deciduars, vernix, caseosa, lanugo, meconium. Lochia serosa contains less RBC but more leukocytes, wound exudate, mucus from the cervix. Lochia alba contains plenty of decidual cells, leukocytes, mucus, fatty and granular epithelial cells. Amount. The average amount of discharge for the first 5 to 6 days is estimated to be 250 milliliters. It helps in detection of infection. Clinical importance. The character of flukeal discharge gives important information about the abnormal puerperal state. The vulval pads are to be inspected daily to get information. Odor. If offensive, it indicates infection. Amount. Scanty or excessive indicates infection. Color. Persistence of red color beyond the normal limit signifies subinvolution or retained bits of placenta. Duration. Beyond 3 weeks suggests local genital lesions. Episiotomy. Inspect episiotomy thoroughly using flashlight if necessary for better visibility. Use the acronym REDA to guide assessment. R stands for redness, E stands for edema, E stands for ecchymosis, D stands for discharge from episiotomy, A stands for approximation of suture line, edges of episiotomy. Check rectal area for hemorrhoids and provide SIDS bath and local analgesic medication as advised by doctor. Reassure the woman and answer to her question that she may have regarding pain, cleanliness and coitus. Unusual perineal discomfort may be a symptom of impending infection or hematoma. Homan's sign. Make the woman lie on her back. Press down gently on the patient's knee. Legs extended flat on bed. Ask her to dorsiflex her foot. Pain or tenderness in the calf muscles is a positive sign of Homan's sign and indication of thrombophlebitis. To ask for deep vein thrombosis, the lower extremity should be examined for the presence of red, painful and edematous area. Degree of edema in feet and legs should be checked. Provides a sign of detection of deep vein thrombosis. Emotional status. Emotions are an essential element of the postpartum assessment. Postpartum patients typically exhibit symptoms of the baby blues or postpartum blues demonstrated by tearfulness, irritability, and sometimes insomnia. The postpartum blues are caused by a multitude of factors including hormonal fluctuations, physical exhaustion and maternal role exhaustion and maternal role adjustment. This is a normal part of the postpartum experiences. However, if these symptoms last longer than 2 weeks or if the postpartum patient becomes non-functional or expresses a desire to harm herself or her infant, she should be instructed to report this to her certified nurse midwife or physician immediately. Throughout the physical assessment, notice and evaluate the mother's emotional status. Helps in detection of any psychological complication in the postnatal period. Post-procedural steps. Give a comfortable position to the patient. Replace all the articles to the utility room. Recording and reporting the findings should be done. If any abnormality found, inform the concerned doctor. Tell the women about the date and time of next visit. Thank you.